Good day, everyone, and welcome to the November Mountain-Pacific Quality Health MDS Coding webinar series. We're lucky to have Jennifer LaBay with us today to share insights about the quality measures, how the MDS impacts this data, and where the best resources are for more information. As a note, all attendees are muted during the presentation, but feel free to chat in questions as we will be monitoring chat. You may also ask to be unmuted if you prefer. Slides and a link to the recording will be sent out following today's presentation. Take it away, Jennifer.
Jennifer, you can start sharing your screen.
Okay, thank you everybody. This is our final big webinar presentation for the year. We will be doing one more office hour at the end of the year in December. So make sure you join us for that as well. So I'm gonna turn on my camera for anybody who may want to know who the heck is talking to them. So today we are going to do a deeper dive into the quality measures. Now, I could probably spend a full day speaking about all of the different quality measures, and our last program that we had kind of gave us an overview, an introduction of where to go to find the information, to find the technical specs, to find the manuals, because sometimes that's part of the puzzle, is trying to figure out where the heck do I go to find out all this information, because we've got a lot of different programs, as we talked about last time. And it's important to understand where to get that manual. And then it's also important to understand how to read those manuals and technical specs. So today we're going to dive a little bit deeper into those manuals and how to decipher what's in those manuals, look at the keys, and try to review some of those more misunderstood and commonly triggered QMs. So we've only got an hour. It's a lot of information to talk about. Certainly, I'm always available for questions. You know, the folks at Mountain-Pacific Quality Health certainly know how to get a hold of me, and we'll have my contact information at the end. So we do have some updates since our last webinar. There was an update to the quality measures manual effective October 1st. We are now in version 14.0 for the MDS 3.0 quality measures. And then the SNF QRP measure calculation also updated October 2020. We are now in version 3.0.1. So those references that we talked about, just be aware that we are now updated. So if you had downloaded anything, or instead of just bookmarking those spots to download, there was an update, because that's what happens. It's a constantly moving target sometimes. So in order to know what we're looking for in the logic specifications and how to decipher that, it's important to review some of the definitions that are in the manual. The MDS 3.0 manual is set up with these definitions at the beginning. We will focus mainly on MDS 3.0 QMs today, with some SNF QRP thrown in for good measure. So let's take a look. So we do have a target period definition. The target period for MDS 3.0 in the CASPR reports can be user defined. So this is the span of time that defines that quality measure reporting period. It could be a calendar quarter, could be if you choose to do a month, if you choose to do 6 months. When you do pull the report, it's going to pull it for a 6-month period. I always like to pull that 6-month period, what shows up when you go to pull that report in CASPR, because that's what the surveyors are going to pull, is that 6-month look back. Then you can also pull up whatever time period you'd like. You need to keep in mind that when you are pulling up that information, you want to make sure you have enough of a reporting period that you include your entire your census, because if you only pull up a month, you're probably not going to get everybody, because we do our assessments every quarter. So you want to have enough of a look back period, of a target period, so that you can have usable data. The SNF QRP target period is the span of time that defines the quality measure reporting period. So it's a 12-month calendar year, and that is what we're looking for the quality measures for SNF QRP. MDS measures are 12 months or 4 quarters, and the claims base are also a 12-month target period. The percentage of short stay residents who were rehospitalized after a nursing home admission, the numerator and denominator includes stays that start over that 12-month period, and that data is updated every quarter. The number of hospitalizations per 1,000 long stay residents, that's also looking at a 12-month target period for all the days after the resident's 100th cumulative day in the nursing home. So there's little bits of differences between each of the quality measures. So it's important to look into that individual logic and determine which one am I looking for. So our friend COVID always has an effect on everything because it's 2020 and that's how we roll. There has been an effect, obviously, on what's been going on with the public health emergency and our SNF QRP quality measure target period. So there was a tip sheet that went out, which is on the link on the screen. There was an update in October. There was a tip sheet that went out over the summer as well. So for our target period for our SNF QRP quality measures, Q4 of 2019 is optional for the data submission, but Q1 and Q2 of 2020, those are accepted. Those are not going to be used. Even if you submitted data, that information is not going to be used for the calculation of the SNF QRP quality measures in light of everything that has been going on this year. They have also put a freeze on the assessment based measures for the upcoming data refreshes. So the October 2020 was a normal refresh because that included the Q4 2019 data. That was the inaugural posting of 6 new quality measures as well. There is a freeze on all of the quality measure refreshes, the nursing home compare refreshes in January, April, July, and October of next year. And then January of 2022, the public reporting will resume, and then there will be a normal refresh in April of 2022. So this is to account for that, that missing data for Q1 and Q2 of 2020. They will be doing some updates to that calculation on CMS's end. So that's an important thing to know, but that doesn't mean that we shouldn't be mindful of how these items are calculated and what it's going to look like, because we certainly don't want to have, all of a sudden have normal refresh starting in April of 2022 or January of 22, and then everything kind of tank because we've haven't been paying attention to what's been going on because it hasn't been reported. So we want to make sure that we're still aware of all of the definitions and instructions and that we're keeping up with our quality, because the only thing it's going to hurt is the resident. If we don't have good quality of care, we're not going to be doing any favors to our residents. So we want to make sure that we're staying on top of it. So our next definition is a stay. So a stay for MDS 3.0 is the period of time between the resident's entry into the facility and either a discharge or the end of the target period, whichever comes first. A stay is also defined as a set of contiguous days in the facility. So the start of the stay is either an admission entry or a re-entry into the facility. And the end of the stay is the earliest of the following. Either they were discharged with an OBRA discharge assessment, or they died, or you just hit the end of your target period. So that just could be your own user-defined target period. For SNF QRP, the stay is a little bit different. This is going to include consecutive time in the facility, starting with a Medicare Part A admission, because SNF QRP, don't forget, is looking just at our Medicare admissions. So MDS 3.0 quality measures is looking at everything. And the SNF QRP is only looking at your Medicare So we're looking at the Medicare Part A admission record, which is your 5-day assessment, through the Medicare Part A discharge record, which is your PPS end of stay assessment, either combined with the OBRA discharge or as a standalone, or a death in facility tracking at the end of that SNF stay, and all intervening assessments. The Part A stay is could also include interrupted stays that last 3 calendar days or less. So this isn't a PDPM PPS presentation, but we know with our interrupted stays, if they leave Medicare coverage, their last covered day or their first non-covered day, if they are back on Medicare coverage by midnight the 3rd calendar day after that, that would be an interrupted stay. So we have 2 types of stay with the SNF QRP. A type 1 stay is a stay that is going to be a 5-day assessment that is matched with a PPS discharge assessment and no death in facility tracking record within that stay. A type 2 stay is if you have a 5-day assessment and a death in facility tracking. So the type 1 is looking at those folks who have both the SNF PPS 5-day and discharge assessment, because we know when somebody dies, when they're covered under Medicare Part A, they only have the death in facility tracking. They wouldn't have that PPS end of stay. That's not required. So that's why they have 2 different types of stays for tracking. For our 3.0 quality measures, we have a couple of different stays that we need to look at. A short stay versus a long stay. And this is looking at the type of quality measure, not the type of resident. So this is a lot of times where there's some overlap and confusion due to the terms that are used. The short stay and long stay definition have nothing to do with a resident's discharge plans. So a short stay quality measure will be calculated on residents who have been in the facility for 100 cumulative days or less. Cumulative days in the facility, CDIF. The long stay quality measure is going to be calculated on residents who have been in the facility cumulatively 101 days or more. Since your target period is adjustable and user definable, if you pulled a quality measure report with a target end date of today for a resident with cumulative days in the facility of 100, today they would calculate a short stay quality measure. But if you ran that same report tomorrow with the target end date of tomorrow, that same person now has been in the facility 101 days. And now that same person is going to calculate into a long stay quality measure. So the long stay and short stay quality measures are mutually exclusive, meaning they can't trigger for both at the same time, because obviously they're either going to be in the facility 100 days or less or 101 days or more. You can't have them both at the same time. For our SNF QRP quality measures with our incomplete and complete patient stays, so we've got a type 1 stay, a type 2 stay. A type 1 stay is one that has a matched 5-day and PPS discharge. There's also an incomplete and complete patient stay that we have to be mindful of. With the incomplete Medicare stays, this will affect the completion of your Section GG column 3 discharge performance. And potentially your column 1 admission performance if the stay is less than 3 days. Incomplete stays are also exclusions for the functional outcomes measures because there is no discharge performance of Section GG calculated. So for our folks with an incomplete SNF Medicare stay, that means they've had an unplanned discharge. This is going to be a type 1 stay because they're going to have a PPS discharge completed. It's an unplanned discharge as indicated by A310G, or they've discharged to the acute hospital, psychiatric hospital, long-term care hospital, also is indicated per Section A of the MDS, or they've had a SNF stay of less than 3 days, or the incomplete stay would be that they've had that resident death was indicated. The complete Part A stay is going to be anybody who didn't meet that criteria. So it's important to understand there's lots of different pieces that are looked at And we have to know the definitions of all of those if we want to truly understand, why did this trigger, but it didn't trigger for that person? Oh, I see why, because it was an unplanned discharge. So we don't have to calculate it for that particular person. Another definition we're looking at is an episode. Episode is under the MDS 3.0 quality measure definitions. There is no definition for an episode in SNF QRP. So an episode is a period of time that spans one or more stays. An episode is going to start with an admission entry, and the end of the episode is the earliest of the following: a discharge assessment with return not anticipated, a discharge assessment with a return anticipated, but they did not return within 30 days, or a death in facility tracking, or the end of the target period. So what is the difference between a stay and an episode? A stay can end with any type of discharge. So that's going to be a discharge return anticipated, but that the episode is going to be a final end, that final discharge, that discharge assessment where they're not having a return anticipated, or they are a return anticipated and they don't come back within that 30 days. So that ends that episode. You can come in and out of the hospital multiple times and have several stays within one episode. But as soon as we meet one of these ends, that discharge, return not anticipated, that greater than 30 days, or the death, that's the end of that episode. Admission, so we have a couple of definitions here for our MDS 3.0 quality measures. An admission entry record is required when any one of the following occurs: the resident's never been in the facility, or they've been in the facility previously and were discharge return not anticipated, and now they have come back, or they've been in the facility previously, discharge return anticipated, but they didn't return within 30 days of the discharge. So those are the same definitions as the admission type of entry in MDS itself for your type of entry. And that is going to determine whether you need to start a brand new schedule again with your admission assessment and start all over. The definition of Medicare Part A admission for SNF QRP is looking at your Medicare admission. So it's not the admission into the facility. It's talking about, do we have a 5-day assessment? 5-day assessment is your admission assessment to Medicare. And that is that first Medicare required assessment, only Medicare required assessment now, to be completed when the resident is first admitted or readmitted to the facility for a Part A stay. So their reason for entry into the facility could be a re-entry, but this is going to be their Medicare admission record if we have to do a new 5-day assessment. So there's similar words, but definitely differences between the two programs. A re-entry, there's only a definition under MDS 3.0. There is no re-entry definition in SNF QRP. This is required. This is the record that is required when all of the following occur: that the resident was discharge return anticipated. They're in your building, their discharge return anticipated, and they returned to the facility within 30 days of discharge. So all of those must be met, versus the admission where it's any of those items. So all of these conditions have to be met. Again, same definitions as it is for your entry type in Section A of your MDS and RAI manual. For Medicare end of stay, this is a SNF QRP quality measure definition. For the end of stay, we're looking at that Part A PPS discharge record. It's either going to be a standalone assessment or combined with the OBRA discharge, but that is going to indicate when that PPS stay has ended. And that is going to determine what the criteria is for calculating those SNF QRP quality measures. And we know that with an interrupted stay, although there may be an OBRA discharge, there would not be a SNF PPS discharge completed at that time. So this is solely looking at that SNF PPS discharge. Numerator is another definition that we need to be aware of. For MDS 3.0, this is the number of residents who actually have the qualifying quality measure condition. And SNF QRP, instead of looking at the residents, it's looking at the total number of stays, Part A stays that meet the criteria for the measure numerator in each facility. The denominator for MDS 3.0 is the number of residents who could have had that qualifying QM condition, versus the denominator in SNF QRP is, again, looking at stays, not residents, the total number of Medicare Part A stays that don't meet the exclusion criteria for each facility. So even though it's the same terms, it's used differently across the different programs. Some additional key definitions and target keys that we would want to understand. When you're looking at the logic specs for your quality measures, anytime you see a dash with brackets around it, that's the not assessed code. So if we code a dash on the MDS and we see it on the form like this, everything has brackets around it. That is what that is meaning. So something is dashed on the MDS. Should be rarely used, as we know. We know it's an appropriate code, but it should be rare. If you see brackets with this little, the arrow up, it's a caret. That's what it's called, the official name for it. This indicates that there is an MDS skip logic applied. So if you look in your MDSs, if you were to print them out, or sometimes depending on what type of software you have, if there's a skip pattern, a lot of times your softwares might gray it out or won't let you answer it. If you actually printed out and looked at how those items looked when you print them, they're not blank. There's actually going to be those little carets in there, which indicates that that was part of the skip logic. So that's what that means, that caret. If there is a number, bracketed number, number 1, you have to understand what part and what question of the MDS you're looking at. If the MDS question that you're referring to is something that is checked, so a checkbox item on the MDS, when you're referring to that type of question, a bracketed 1 means that yes, that particular item was checked in the checkbox. If you are looking at a bracketed number and you're referring to an MDS question or an MDS item that is answered with a number, then that bracketed number is referencing the number you actually used to code that question. So you kind of have to have a blank MDS with you while you're looking at these technical specs to see, which A, because they're not going to tell you that the names of the items. They're just going to give you the item numbers and the questions, and you'll have to look it up on the MDS to see exactly which one they're talking about, because sometimes it can get a little confusing. And if you don't know those little inner intricacies, it may be difficult to read. So this is a little bit hard to read, but this is the actual table from the % of low risk residents who lose control of their bowel or bladder. This is a long stay MDS 3.0 quality measure. There is more information you need to know about how to interpret these logic specs. In addition to the definitions and in addition to the key that I showed you before, you have to know which question is answered. So as you can see, the highlighted H300 in the brackets is 2,3. So if you have your MDS, you would have to look up to see particularly how this particular item is coded. So H300 is looking at the urinary continence. And in order to know what 2 and 3 mean, you'd have to look at your MDS. Okay, 2 would be frequently incontinent, 3 would be always incontinent. So that's going to help you understand what they mean by what's in this technical spec. Because maybe you do know that that's what those different things are. I still have to look it up on the MDS. I don't know every single item, every single answer off the top of my head. If you look on the bottom of the screen, this is going to be an example of the checkbox. So if you knew what H100 was, that's the appliances. There aren't numbers assigned into this. It's actually a checkbox. So if they're saying H100C, and you look at your MDS, H100C is ostomy. Ostomy with a 1 with a bracket around it, that means that ostomy would be checked off. If it was dashed, that would also be an exclusion. Well, how can you dash a checkbox, you say? You'd be surprised. If you are in your electronic record and you click on the checkbox to check it, and then you click on it again, there will be a dash there. So don't get too click happy, because you might be dashing something inappropriately, which will affect your quality measures. Not in a positive way necessarily. It may exclude somebody that really shouldn't have been excluded. So then you're under capturing and undercoding that quality measure. Now I got ahead of my animations. So another key to understand what we're looking at is something in the covariates. So this is the covariate for improvements in function. So covariates are those risk adjusters. And this is going to show you the risk adjuster is if you code this, but it doesn't just say this is your covariate. It gets a little tricky. So in this situation, covariate equals 1 if A800 is 2, female. Well, covariate equals 1 means, yes, this is the covariate. The covariate applies if you answer this. Then covariate equals 0, that would mean, well, if you code any of the rest of this stuff, they don't trigger for the covariate. So when they're talking about covariates, 1 equals yes, 0 equals no. Doesn't really say that anywhere in the manual. That was something that I kind of just had to figure out just by the logic of everything. Another definition, we talked about it a little bit a second ago, the cumulative days in the facility. So the cumulative days in the facility for MDS 3.0, these are the total number of days within an episode during which the resident was in the facility. It is the sum of the number of days within each stay included in an episode. So if an episode consists of more than one stay, and then there's periods of time outside of the facility, then that is not going to count towards that cumulative days. It's only going to be the days in the facility that count towards this calculation. SNF QRP quality measures are not calculated based on cumulative days in the facility, but rather the Medicare stays. Risk adjustments. So risk adjustments refine the raw quality measure data. The risk adjustments could be exclusions of residents from triggering in the denominator, or there could also be a covariate. So the covariate is going to be something that kind of evens the playing field. They know that the quality measure is going to trigger, but it doesn't count as much against the facility because we knew that there were some extenuating circumstances or covariates that may have been coded on the MDS. So meaning it improves the quality measure score. Exclusions, those are the biggest risk adjustment. They completely remove the resident from the denominator altogether. So they're not going to trigger for that quality measure at all. It's very important to know what those exclusions and covariates are. Not that you want to apply them inappropriately, but it's helpful to understand where it comes from because, oops, I forgot to code that, even though it's something that is affecting that resident, it does affect the covariate, we want to make sure that we're capturing everything appropriately. There are 5 MDS 3.0 quality measures that are adjusted using those covariates for the public reporting. The pressure ulcers that are new or worsened, the improvement with performance, transfer, locomotion, walking, and corridor, the % of residents who self-report moderate to severe pain. Now that has gone away, but if you are looking at older data, that will still be on the report. % of residents who have or had a catheter in their bladder, and the folks who have declined in independence and locomotion. And then these are our SNF QRP quality measures with covariates. Again, the pressure ulcer, that is the same actual calculation as it is for the MDS 3.0. MDS 3.0 has adopted the SNF QRP calculation for the pressure ulcer. They are only listed in the SNF QRP manual. They do list both of the old pressure ulcer quality measures and the current to calculate anything through September 30th of 2019. So it all depends on where you are pulling your information and what your reporting periods are will have an impact on which quality measures are actually triggered because some of those quality measures have been retired. These 4 quality measures that are risk adjusted have a lot of risk adjustments associated with them. There's a whole slew of them. Our calculation, there's many different methodologies that can calculate somebody into a quality measure. For your MDS 3.0 quality measures, you're going to calculate them, some of them looking at the most recent MDS in the reporting period. Some are comparing the most recent MDS to an initial MDS. Some are looking at the entire episode in that target period and they scan all of the MDSs. That's a look back scan. And some compare the most recent MDS to a prior. The definitions and timeframes will vary between the short stay and long stay quality measure calculations. So let's look at our short stay quality measures that use a target assessment. The selection period is the most recent 6 months. This is the short stay target period. The qualifying reasons for assessment is going to be any OBRA or scheduled PPS or OBRA discharge assessment. And this is looking at the latest assessment that meets the following criteria. It is contained within the resident's selected episode. It has a qualifying reason for assessment, and its target date is no more than 120 days before the end of an episode. A short stay episode can span more than 100 calendar days because days outside of the facility are not counted in defining that 100-day or less short stay episode. The target date being no more than 120 days before the end of the episode, that allows for 93 days in between the quarterly assessments, plus an additional 27 days to allow for late assessments. The target assessment represents the resident's status at the end of the episode. So that's your target assessment with your short stay. There's also short stay quality measures that use initial assessment methodology. The selection period first is going to be the first assessment following the admission entry record at the beginning of that resident's selected episode. Again, your reasons for assessment: OBRA admission, PPS 5-day, or OBRA discharge. Any one of those 3 could be the first assessment after that admission entry into the facility. The selection logic is going to be the earliest assessment that meets the following criteria. It is contained within the resident's selected episode. It has a qualifying reason for assessment. It has the earliest target date that is greater than or equal to the admission date starting the episode, and the target date is no more than 130 days prior to the target date or of the target record. The initial assessment cannot be the same as the target assessment because you can't compare one assessment to itself because there's no difference in data there. Some of the quality measures are looking back to compare to that initial assessment, such as the resident's newly on antipsychotics. This uses a look back scan and an initial assessment comparison. The 130 days prior to the target allows for as many as 30 days of a 100-day stay to occur outside of the facility. So that's why it's 130 days. Our short stay quality measures that use look back scans, this is scanning all of the assessments within a current episode. So this is the percent of residents who newly received an antipsychotic, as I said. The reasons for assessment: OBRA, scheduled PPS, or OBRA discharge. The logic is including the target assessment and the qualifying earlier assessment in the scan. It includes an earlier assessment in the scan if it meets all of the following criteria. It is contained within the episode, it has a qualifying reason for assessment, and its target date is on or before the target date for the target assessment, meaning you can't have the same assessment comparing it to. So with the percent of residents who newly received antipsychotic medications, that means that on their initial assessment, they didn't have antipsychotics, And then on the next assessment, they did. So that's what that's looking for. Since PDPM and decreased Medicare assessment schedule, it's probable that there will be a decline in triggering this quality measure, but it's also, it could. It depends on if you are separating your assessments. Long stay quality measures that use the target assessment. So we are now looking at our long stay measures, which is calculated on folks who have been in the facility, cumulative days in the facility, 101 days or more. So our target assessment for our long stay measure, instead of looking back 6 months like it did for the short stay, this is only looking back at the most recent 3 months. The qualifying reasons for assessment are OBRA, scheduled PPS, or OBRA discharge. And the selection logic is going to be the latest. So this is the latest assessment at the end of that period that meets all of the following criteria. It's contained within the episode, has a qualified reason for assessment, and its target date is no more than 120 days before the end of the episode. Again, that 120 days allows for 93 days between the quarterly assessments plus an additional 27 days to allow for late assessments. An example of this is the high risk pressure ulcer, pneumococcal, the UTI, the loss of the control of bowel or bladder, indwelling catheter, restraint, weight loss, depressive symptoms, the long stay antipsychotic, anti-anxiety and hypnotic use, and the behavioral symptoms. Those are all looking at target assessments. So what is the latest MDS in this period, and did it meet that criteria to trigger that quality measure? Long stay quality measures that use prior assessment. So this is a comparison. It's comparing the current target assessment to the prior MDS. The prior MDS has to have at least 46 days in between ARDs from the target assessment to the prior. So if you are in a situation where maybe you've done multiple assessments, either you're in a case mix state and you have to do multiple assessments to adjust your case mix, or maybe you've had some SIG changes going on, it's not going to affect the quality measure unless there's 46 days in between. So you could have an MDS done as the target assessment, an MDS you did a month ago, and then an MDS that you did 3 months prior to that. The comparison is not going to be between the one that you did a month ago. It's going to be the one prior to that, because there has to be 46 to 165 days in between. It's not looking at those that are less than that. So our reasons for assessment here: OBRA, scheduled PPS, OBRA discharge. It's looking at the latest assessment that meets the following criteria. It was in the episode, it met the qualifying reasons for assessment, and its target date was contained in the window that is 46 to 165 days preceding the target date of the target assessment. If there is no qualifying assessment that exists, the prior assessment is considered to be missing. The quality measures that look at this methodology, the percent of residents whose need for help with ADLs has increased, so our ADL decline. The percent of residents whose ability to move independently worsened, which is our decline in the locomotion on unit. So it's very important to understand there has to be that at least 46-day gap in between. The long stay quality measure look back scan. So this is going to be these quality measures that, well, they didn't trigger for this on the last assessment. How come I'm still triggering for this quality measure? It's this darn look back scan. We have to understand what the calculation is. So the selection period is all assessments within the current episode that have target dates no more than 275 days prior to the target assessment. So the 275-day look back does not start with the end of your target period. It's going to start with that target assessment. So you have your target period, and we have an assessment that they're not quite due for their next assessment. So the last assessment that it was in this target period was almost 3 months ago. Your 275-day look back goes backwards from that assessment that was 3 months ago. So you could be looking at about a year of assessments to calculate, and any of those assessments done in that almost year, depending on when your target date of that assessment is, all of them are going to be looked at to see if that quality measure applied. So it could take almost a year to get this quality measure off of your report. Reasons for assessment, again, the OBRA, the scheduled PPS, the OBRA discharge. The only scheduled PPS assessment there is a 5-day. IPAs do not count towards any of the quality measure calculations, either in quality measures for 3.0 or the SNF QRP. So it's just the 5-day. That's our only scheduled assessment now. The selection logic includes that target assessment. So we're kind of looking at two things. We're looking at a target assessment, and we're also looking at a look back scan. And all of those qualifying assessments in that scan, 275 days from the ARD of that target assessment. And these are the ones that fit that criteria, that fall with major injury and the prevalence of falls, which is your survey only measure. So those are the different methodologies that could be calculated on the long stay and short stay quality measures. So now, how do we read the individual quality measure logic specifications? So this is an MDS 3.0 QM logic specification table. This is for our percent of residents with a UTI. This is the title of the QM and the ID numbers from CMS. This section is a description of the quality measure. This item is the specifications, including the numerator that we already talked about. That's the number of residents who triggered for the quality measure. And then the denominator, which is the total number of residents who could have triggered for that. And then the exclusions. So any exclusions for the quality measure will be listed right under the denominator. That's going to take the folks right out of the denominator, so they can't trigger for that at all. Then there are covariates that will be applied to the denominator. And then at the bottom, there may be a footnote that will give some extra information, such as in this case, this measure is also used on the 5-star quality rating system, or this measure is not reported on Nursing Home Compare and is only available on the Casper QM reports. So that's the basic setup of how to read each logic spec. So let's take a look at some of the more confusing logic specs that are out there. This is the SNF QRP definition. It's only found in this manual. This is your changes in skin integrity, post-acute care, pressure ulcer for your short stay. So it's going to give you some background about the measure description, and then it's going to tell you how do you get into the numerator, and what we're looking at. So for this calculation, it's only looking at type 1 SNF stays. It's looking at your stage 2, your stage 3, your stage 4 pressure ulcers that are coded greater than 0, meaning they have at least 1. Also looking at the unstageables coded greater than 0, having at least 1. And then the denominator, again, looking at Medicare stays, because this is the SNF QRP calculation, and that is the same definition across the MDS 3.0 and the SNF QRP. When you go to look up this particular measure in the MDS 3.0 quality measure manual, it's going to refer you back to the SNF QRP manual. Some potential missteps with this, not accurately assessing the stage of the wound on that first assessment. That's huge. If you don't have a good understanding of staging, if you have a misunderstanding of the REI definitions from the other wound care team members, such as coding a stage 2 with granulation. Per the REI manual, the coding tips, the stage 2 pressure ulcers by definition have partial thickness loss of dermis, and granulation tissue, slough, and eschar are not present in a stage 2 pressure ulcer. So we shouldn't be coding that. You always want to clarify the stage when the granulation, slough, or eschar is present. And that can be found on page M-13 of your REI manual. So this is our falls with major injury. This is our long stay look back scan reported on Casper, publicly reported, and 5-star. This is a look back scan assessment. So whatever the last assessment was in the target period, you then have to count back 275 days, and all of the assessments done in that 275 days are going to be reviewed to see if they met that fall with major injury. So this is the SNF QRP calculation for the falls with major injury. Slightly different because what we're looking at here is the stays. It's got the same name, it's the same quality measure, it's the same idea, but they're looking at Medicare stays and looking at the difference between type 1 stays, type 2 stays. So you may trigger your fall with major injury on your MDS 3.0 quality measure, but depending on the type of Medicare stay, it may not trigger on your SNF QRP quality measure. You have to understand all of those little nuances of what gets you into each program. Some potential missteps with fall with major injury for either the QM programs: under calculation of the quality measure due to misinterpretation of the RAI manual with those discharge assessments. If a major injury related to a fall during the observation period is discovered after discharge, the discharge MDS must be modified to include that injury, even if it was noted after the ARD. In the emergency room, in an X-ray, in an MRI, and a CAT scan in the hospital. The reason being is this is the only place this quality measure is going to be captured. If they come back into your facility, yes, the fall is going to be captured in J1700 of the MDS, but it's not going to calculate that quality measure from that section. It's calculating from J1900, which is showing that fall with major injury, which is only looking back to the date of admission. So it is possible that if you are not familiar with that coding definition, that you may be incorrectly looking like you don't have falls with major injury when you actually do. This is the percent of high-risk residents with pressure ulcer. This is the long stay measure, Casper, publicly reported, and 5-star. This is one of the items that is looking at a target assessment. So we are looking at our stage 2 through 4 or unstageable pressure ulcers that are present. Not that they've gotten worse, but that they just have them. The exclusions would be if their target assessment was an OBRA or admission assessment, a PPS 5-day. And if they didn't have any of the pressure ulcer conditions, obviously they're not going to trigger. There are some covariates, so it is important to understand, what those covariates would be, or what that high risk would be if they are coded with malnutrition or risk of malnutrition or comatose. Obviously, they're going to be high risk. Certainly, folks with those conditions are going to be at a higher risk. Some potential missteps with this high risk. Confusing the definition with the short stay measure. So this is a different measure. We're not looking at a worsening or a comparison. We're just looking that they actually have the wound present. Also, another risk or of misstep is not incorporating the documentation to support that high risk, or coding the high risk criteria when it isn't supported by documentation. So malnutrition and risk of malnutrition, that comes from section I. And that has to be supported by MD or non-physician provider documentation in the 60-day and 7-day look back periods. You can't just go by what the dietitian says or what the BMI is. It has to come from the physician. It's a diagnosis. Even the risk of malnutrition is a diagnosis. And anytime you capture anything in section I, there has to be a physician or non-physician extender diagnosis and documentation to support that. Percent of residents with UTI, again, looking at target assessment, Casper, public report, 5-star. There's certain criteria that you need to meet in order to code this on the MDS. So some potential missteps here would be capturing the UTI on the MDS when the RAI coding criteria isn't met. The UTI has a look back period of 30 days versus the 7 for the rest of the section I. And you are going to code this only if both of the following are present. So if it was determined that the resident had a UTI using evidence-based criteria, such as McGear's, NHSN, Loeb, whatever you use, and there's physician documented diagnosis of UTI or non-physician provider in the last 30 days. If there is no documentation or signed order adding UTI to the diagnosis during that 30-day look back, then UTI should not be captured on the MDS. So beware of documentation of UTI only by nursing staff. So on Bactrim for UTI, but there's no documentation anywhere that says that there is a UTI from the physician. So sometimes I believe that due to the lack of documentation, sometimes the UTI is over captured on the MDS because they don't meet that criteria. There is no doctor supporting documentation of that UTI. And there's no evidence that they met the criteria from the McGear's or, those other evidence-based criteria. The MDS coordinator needs to have access to what calculates them into that evidence-based criteria. It can't just be hidden away somewhere. That's part of what determines whether it gets coded on the MDS or not. Percent of residents who have had a catheter inserted in their bladder. Again, this is a target assessment. Casper publicly reported 5-star. Remember that covariate, if it equals 1, that means the items following that are going to trigger the covariate. Covariate equals 0 means that the following do not trigger the covariate. Some potential missteps here with the catheter. Undercoding due to inaccurate documentation to support the exclusions. If a catheter is in place, the MD or non-physician provider should be asked for the clinical reason. If they say urinary retention, okay, let's query again and ask if the medical cause of the urinary retention is known. We can't just make assumptions. Just because somebody has BPH does not automatically mean that you can capture obstructive uropathy. And we can't ask the MD to just give us that diagnosis. Hey, doc, can you give us neurogenic bladder or obstructive uropathy for this catheter? We're leading the doc to give us information that's going to exclude them from the calculation. We have to go by what the physician's clinical assessment of the reason for that catheter is, and that's all we can go by. We can't, add a little information for that note for the doc to add it. It has to go by clinical criteria. If there is no clinical cause, then why do we have the catheter? Perhaps it can be discontinued. This is our folks with our activities of daily living that has increased. This is looking at a target and prior assessment. Casper, publicly reported, and 5-star. So here we're looking at the 4 late loss ADLs in section G. We're comparing the current assessment to the prior assessment that is at least 46 days prior to this current assessment. There is a trigger to this quality measure if there's a change of coding of 1 point across 2 ADLs or 2 points across 1 ADL. So for the 1 point across 2 ADLs, if the previous assessment was bed mobility and transfer were independent, and now the current assessment, bed mobility and transfer are supervision, that's a 1 point change because it went from 0 to 1 in 2 different areas. It doesn't seem like a huge change, but it meets the criteria. Or if there's a 2 point change in 1 ADL, so if the last assessment toilet use was independent and now they're coded as limited assist, this is a very easy quality measure to trigger. It's very important, for that ADL decline that we are assessing this information accurately. The other quality measure that is looked at for ADLs is our percent of residents whose need for help with activities of daily living has increased. So, and our locomotion on unit, that's another one that's looking at the ADL. So this is looking at the exclusions for that ADL decline. If they were on the previous assessment, all 4 ADLs were totally dependent, they can't get any worse than that, so they're excluded. If 3 of the late loss ADLs were totally dependent and 1 was extensive assist, they're only going to have a decline of 1 point in one ADL, so they're not going to trigger. Those are just logic things. If they were comatose, if they have a life expectancy of less than 6 months, if they're on hospice care, or if you've dashed out anything. So there are some exclusions here. But the key to capturing or not capturing, because we don't want to trigger this ADL, is to make sure that we understand on that very first assessment, accurate assessment of coding section G. Use that REI manual, understand that rule of threes. It's actually not very difficult to be coded as an extensive assist using the rule of threes, making sure that we are assessing all of the episodes of care individually and not just going by that CNA documentation that's once a shift. If it's possible that you can actually code your MDS as an extensive assist from day one of your observation period using that rule of three. The worst that they can be is an extensive assist. If somebody was an extensive assist 3 times on one shift, they can't be any worse than that because totally dependent has to happen 24/7. Totally dependent, independent, activity did not occur is an all or nothing code. There is no rule of three applied to it because it has to happen every single time. Also, not looking at the exclusions and assessing the exclusions properly. Coma, hospice, life expectancy of 6 months or less are all exclusions. Percent of residents who lose too much weight, again, looking at a target assessment. This is Casper and publicly reported. And some potential missteps with this one, inaccurate coding due to misinterpretation of the look back period in the REI manual. So this is our section K, weight. Base the weight on the most recent measure in the last 30 days. Then when you're doing your comparison, you're comparing the weight at a point closest to 30 days preceding the current weight, not 30 days preceding the ARD. It's 30 days preceding the current weight. So if your current weight was 30 days ago on your current ARD, then your 30 days prior to that would actually be 60 days prior to the ARD. So if your dietitian or whoever's completing this section doesn't have a good understanding of what their look back periods are, this could definitely be a skewed calculation. So make sure that whoever's completing this understands that it's a very different look back and it's not just 30 or 180 days from the ARD itself. The percent of residents whose ability to move independently has worsened. This is a target assessment and at least one qualifying prior assessment. This is looking at a decline in locomotion on unit, comparing the current assessment to the assessment immediately prior. Again, 46 days in between. There's a lot of covariates with this, so I don't have the entire thing listed. These are some of the covariates, eating, toilet transfer. There's a lot of them. So if you'd want to know those, look particularly close at that. Some potential missteps. I know I'm running out of time here. Some potential missteps, not understanding the components of locomotion on unit. Locomotion on unit is locomotion in room and adjacent corridor. Locomotion in room is a component of this ADL and must be considered in addition to the locomotion in the adjacent corridor, which is the other component of the ADL. So if the only locomotion that occurred was locomotion in room, which would be likely for any of our folks who are on COVID isolation or quarantine, then the locomotion on unit would only compromise of the locomotion on room, in the room. Don't code them as activity did not occur unless they were bedbound, because if they moved around in their room, then they also moved around on their unit. The components of ADLs are discussed on page G-3 of the RAI manual, if you want some additional information on that. Another problem, not assessing the ADLs thoroughly on all assessments, like we talked about with the ADL decline, and not assessing those exclusions properly. The coma, the hospice, life expectancy are all exclusions. Behavioral symptoms affecting others. This is a Casper only for survey. It only looks at the actual behaviors 4 to 6 days or daily, not the effect on the resident themselves or others. Some potential missteps here, not understanding the REI manual coding instructions, only relying on what the person responsible for completing Section E has personally observed, not interviewing the direct care staff, not reviewing the medical records, justifying behaviors and not capturing them on the MDS, nursing staff not documenting on those behaviors anymore because it's kind of normal for them. Well, they always do that. Well, we still have to document it and code it on the MDS. And then misunderstanding of the definition of rejection of care. So there's a lot of good tips and information in the REI manual about these special populations. Page E-5 of the REI manual has some nice tips and information about rejection of care. Obviously, there's a whole instruction there. Some of the SNF QRPs, just quickly to talk about the long-term care hospital patients with admission and discharge functional assessment. This is our section GG items. We are looking for SNF QRP a 12-month target period, making sure that your column 1 and column 3 items of section GG do not have a dash. We need to assess all of those items that are calculating. And then we also need to make sure that at least one of the self-care or mobility items has a discharge goal. Column 2 can have dashes, column 1 and column 3 cannot, otherwise you will not calculate this quality measure appropriately. And as we talked about, if 20% or more don't calculate accurately, you could lose 2 percentage points of your Medicare payment the following fiscal year. Not understanding how to complete it is a potential misstep. If your staff doesn't know how to calculate what is the usual performance, if they don't understand how to use 9 not applicable, which could potentially probably be coded as not assessed, but they don't want to put not assessed because we know that that's a problem. So we're going to code 9 because it's not applicable. 9 not applicable is used when a resident could not perform that ADL activity before their, it's supposed to be acute illness, not accurate illness, mind my typo, injury, exacerbation, and they still can't. So a resident with a tube feed at home wasn't eating by mouth, and now they're in your facility for aftercare of fractured hip. They still have the tube feed and they still can't eat by mouth. So they couldn't eat by mouth before and they still can't. That would be a 9. Versus maybe they could eat before they've had a stroke, they had the tube feed placed and now they can't. That would be did not do because it was medically inappropriate or not safe for them to do that. And a self-care or mobility item, if it wasn't attempted to be assessed because the staff didn't know that they should do it, then that technically should be a dash. If they attempted it and the resident didn't do it for one of the reasons they refused, they were medically unable, it was unsafe to do so, there was an environmental issue, or they couldn't do it before and they still can't, then that would be appropriate. But if you just, oops, forgot to assess it, then that's a dash. So speaking of dashes, that was kind of a dash through our deeper dive. Like I said, we could probably talk about this subject for hours. I know that we're past our time. But I'm certainly, happy to answer any questions for those who want to hang around. You can always reach me with any questions here at my email or phone number. Shoot me a text, shoot me an email. If I'm available, I'll help you. And if not, you'll just wait a little bit longer and eventually I will help you. So I do like answering questions and helping out everybody because it is tricky. It's a tricky road to navigate.
Jennifer, I was just going to add too for folks to reach out and contact you if you're looking for your MDS training, as Jennifer is doing that virtually. And so for those of you that are wanting or needing some training, Jennifer has left you her contact information, and we just will help you connect.
Great, thank you. Yes, I got lots of classes scheduled with ANAC next year, the certification and the advanced certification, all different time frames to make people from Rhode Island to Montana to Wyoming to California to Hawaii and to Alaska and everywhere in between happy with their times. That's not just all East Coast times.
I'm not seeing any questions in either chat or our Q&A bank. So you did a great job going over things, and we will just wrap up our webinar today and wishing everyone a great afternoon.
Thank you so much.